Hi, everyone. My name's Cheng-Chia Wu. I'm a radiation oncologist. I practice radiation oncology at Innova in Virginia, but I'm faculty at Virginia Tech as well as Children's National. Here are my conflicts. I'm an advisor for the National DIPG Tumor Board, which I'll talk about a little bit, and I'm also advisor for National Rare Tumor Board. Topics I'm going to go over today are really mostly CNS-based, given the time constraints. And they're largely diseases where technology has started to drive how we treat these cancers. And so we'll start off with medulloblastoma and I'll work our way down from ependymomas, germ cell tumors, and then eventually DIPGs and DMGs. And so a little bit of background, about 10% of CNS tumors in kids are medulloblastoma. Typically, the kids are about 6 years old of age when they're diagnosed. Oftentimes, they arrive in the posterior fossa, but they can metastasize, and they can metastasize to other parts of the brain as well as within the cranial-spinal axis. Historically, the staging was based on size and location of mets, but that clearly has not been the standard now. Mostly what people have been doing is they risk stratify in terms of average risk versus high risk. And these risk factors are largely driven by the extent of surgery, age, as well as whether or not there's metastatic potential. And so the standard of care, at least for this time, is in the setting for average risk medulloblastoma. Typically, kids get concurrent chemotherapy with cranial spinal radiation to 23.4 with a boost to 54 to 55.8 to the tumor bed. In the setting of high-risk medulloblastoma, typically patients get 36 gray cranial spinal radiation with a boost again to 54, 55.8 to the tumor bed. Sometimes a higher dose of cranial spinal irradiation is used in a setting of diffuse metastatic disease in the spine. So we oftentimes treat to 39 gray, but no, this is in special instances. Now, one question that has been answered is whether or not you need to treat the entire posterior fossa. Those in pediatric know that in the COG study, ACNS 0331, the goal of this study was to see whether or not we can de-escalate therapy for kids who have average risk medulloblastoma. The two questions that were asked on the study was one, whether or not we can avoid posterior fossa boost by treating the tumor bed, and the second question was whether or not we can de-escalate CSI dose from 23.4 to 18 gray. Specifically answering the question that we're talking about right now, which is the volume for the tumor bed boost for average risk. What they showed that there was non-inferiority in terms of outcomes. So instead of a posterior fossa boost, you can treat the tumor bed boost, which in many ways makes it easier because of avoidance of the cochlea in terms of hearing preservation. Now, in the setting of high-risk medulloblastoma, the standard of care is still posterior fossa boost. However, many institutes have started to treat high-risk medulloblastoma with tumor bed boost instead. So there's been retrospective studies from Emory that showed in terms of equivalence, in terms of outcome when you do tumor bed boost for high-risk medulloblastoma. In the St. Jude's study, JMB03, in this study, they risk stratified therapy for high risk and average risk, and they applied tumor bed boost for their high-risk patients and showed reasonable disease control and low risk of failure outside of the tumor bed field. So in terms of the role for radiation boost in the setting of high-risk medulloblastoma, the standard of care is still posterior fossa boost, but it is reasonable if the patient has high risk and their high-risk disease is driven by, say, spinal met, and there's just focal disease in the posterior fossa. Many people have used just a tumor bed boost for high-risk disease. Now, clearly, if you have leptomeningeal disease within the cerebellum, then you wouldn't want to do a tumor bed boost. You want to treat the posterior fossa in its entirety. Now, with the risk stratification of surgical extent as well as metastatic potential, this has largely been taken over by the advancements of molecular sequencing. And so in the field of medulloblastoma, largely the disease is split into different subtypes, including Wnt, Saanich hedgehog, group 3, group 4. As you can see in terms of prognostication and outcomes, those who have Wnt driven medulloblastoma have extremely favorable outcomes in terms of overall survival with typical therapy. Those who have group 3 have the worst outcomes, and Saanich hedgehog and group 4 are in the middle. More recently, there's been high-risk molecular factors that can be found in sausage hedgehog, including P53 mutation, which the prognostication of sausage hedgehog is severely worse. Why does that matter? The real reason is because when we, again, thinking back at medulloblastoma, the goal is to see how we can preserve cognition in kids, how we can limit toxicity. And so in the setting of the most recent COG study for low-risk medulloblastoma defined by Wnt non-metastatic medulloblastoma, ACNS 1422 is currently testing, again, the concept of using 18-grade cranial spinal irradiation with a boost. The outcomes are not out yet, but hopefully based on the favorable outcomes for Wnt medulloblastoma, this hopefully will become positive and hopefully become the new standard of care. Now, from there, there's been cooperative groups across the country, trying to risk stratify medulloblastoma based off of these molecular findings. And this was proposed by a cooperative group, including those from Children's National in the setting of Dr. Roger Packer, somewhere here. But long story short is that they've broken it down to low risk, to standard risk, high risk, and very high risk. And then there's subsequent molecular findings that they really don't know how to categorize. And so why this matters is because as we move forward with new clinical trial designs, a lot of the escalation and de-escalation therapies are now based on molecular findings as opposed to just surgical extent of disease. And so some of these risk stratification has actually made it into some level of practice. Because when you look at the NCCN guideline for pediatric medulloblastoma, you can see that aside from, say, low risk and high risk disease, depending on metastatic extent, if you have one or more of the following risk factors, and that includes MYC amplification, TP53 mutation for sausage hedgehog subgroup, the recommendation from NCCN is actually to escalate therapy to treat it as high-risk disease. Now, NCCN is not is a recommendation from expert panel, and so the data in terms of level of evidence for this type of suggestion is not quite there yet. But it just goes to show that the way the field, in terms of where it's going, is largely driven by these molecular risk stratification. Similarly, in this very high-risk group, in terms of MYC amplification in the NCCN guidelines, they're also recommending dose escalation, therapeutic escalation. And so more is to come in terms of how medulloblastoma is going to be treated. But as you can see, early adopters of molecular subclassification and therapy is coming. The current high-risk medulloblastoma study in COG is currently being designed, and it's going to be driven based off these molecular roles. Now, to pivot a little bit, we'll talk about ependymomas. Ependymomas are, again, a little bit more rare, but they're posterior fossa tumors as well. Oftentimes, they occur in kids, but they can also occur in adults depending on location of disease. They're typically localized, but there are metastatic potential for ependymoma, and the common locations in terms of where it could be includes the posterior fossa, supratentorial, and spinal cord. Based on histology and location and grade, the recommendation in terms of therapy is largely driven by these findings. But as we follow the path of medulloblastoma, the application of molecular subcategorization also occurs in the setting of ependymoma. In terms of the prognostic factors of ependymoma based on these subclassification, it's not as robust as medulloblastoma. However, we do know that, for example, if you have supratentorial ependymoma with RELA, or if you have posterior fossa ependymoma type A, the outcomes are significantly worse than others. And so clearly, as we move forward with therapy and escalating therapy or de-escalating therapy, there's a lot of thought into the molecular findings. Now, that being said, though, the most important prognostic features for ependymoma is still the surgical extent. Clearly, if you have gross total resection versus subtotal resection, the outcomes are dramatically different. And there have been studies retrospectively in St. Jude looking at what dose to give and range from 54 grade to 59.4. So why does this matter? The real reason is because when we look at these tumors, oftentimes, especially in the posterior fossa, the surgical extent is difficult. And especially if their first surgery is in a non-high volume center, many a times you may have subtotal resection. And so the question is, what do you do with these patients? In the study ACNS 0121, they basically stratified patients depending on location of disease, the extent of surgery, and the grade. And so for this specific slide, we'll largely focus on the supratentorial grade 1, grade 2 ependymomas. But what they found is that after gross total resection in the striatum, they recommended observation. And so if you look at the data, basically the progression-free survival rates, as well as the failure rates, are quite high. In terms of stratum 1, you have a failure rate of about 40% with observation. However, the overall survival is 100%. And what that tells us is that even though you offer observation for patients with supratentorial low-grade tumors, the salvage capability is very good. So many a times in pediatric patients, especially in the younger kids, if there's an opportunity to observe with gross total resection, that's the preference, largely because we know that at least 60% of the kids won't require therapy. And those who do relapse, at least they're being monitored. And at relapse, you can salvage them with additional surgery and radiation at that time. Now, when we look at posterior fossa tumors in terms of subtotal resection, there are different questions that are being asked right now in the setting of COG. Those include the usage of, subtotal resection followed by chemotherapy, second look surgery. They're also looking at, for example, for poor players after therapy, whether or not there's any role for maintenance therapy. Lastly, one difference in terms of the studies in terms of ependymoma is that even with posterior fossa ependymomas, the recommendation in terms of radiotherapy has been to escalate to 59.4 gray. And so the way they contour this is basically the pre-surgical post-op bed goes to 54 gray, and then clearly depending on the proximity to the cervical cord, proximity to the optic nerves, there's a cone down boost to 5940. And so a typical plan looks something like this. There's a tumor bed plus extension to the 54 gray, then it's tumor bed to PTV with subtraction out of the conus and any sort of risk for optic structures. Now, in terms of the role and the outcomes for this boost, there's been a multi-institutional study looking at their institutional effects and outcomes for boosting these tumors to 59.4. It seems that for all of the patients cohort, when they looked at it, there wasn't a benefit for boosting to 59.4, but when they looked at the grade 2 patients, there seemed to be a benefit. So right now, we're still waiting for the COG studies to come out, but this is an ongoing question that's going on. One thing I wanted to briefly touch upon is what's the role of radiotherapy for myxopapillary ependymomas in the spine? Historically, these tumors were grade 1 tumors, and after surgery, typically, aside from MRI, no further lumbar punctures are done, and essentially they're observed, and patients did quite well. However, unfortunately, fortunately, in 2021, when they had more longer-term outcomes, they found that there are some metastatic potential for myxopapillary ependymoma, as well as higher failure rates when it got to 10 years, 15 years, post-therapy. And so in 2021, myxopapillary ependymomas were upgraded to grade 2 due to these reasons. And so why that matters is because when you look at the NCCN guideline for recommendation, they started recommending the addition of CSF workup in the setting of lumbar puncture after resection. The overall risk for lumbar puncture is low, but there are patients who you do pick up leptomeningeal disease based off of that. And so the therapy, depending on what you find, is based on what you do. The other thing to consider is that from these retrospective studies, they found that the extent of surgery, not just gross total resection versus subtotal, but whether or not this was resected en bloc without capsule violation versus if it's piecemealed in terms of capsule violation, the risk of failure does change. And so for those who have gross total resection en bloc and negative cytology, observation is recommended. But if you have piecemeal resection or you have other risk factors leading to potential for spread, I think standard of care of observation is still very reasonable, but one can have a fair and balanced discussion about the role of adjuvant radiotherapy for local control. Now we're moving to germ cell tumors. As germ cell tumors are very rare in the US, it's a little bit more prevalent in Asian countries. And so when we're looking at germ cell tumors, they can largely be broken down into germinomas that don't produce markers versus non-germinomas germ cell tumors that do produce markers such as AFP and beta-HCG. In terms of the presentation, oftentimes they occur either in the pineal gland or in the suprasellar region. And the clinical symptoms largely depend on where they are at. In the suprasellar region, you may have endocrine dysfunction, you may have bitemporal hymenopsia, you may have different growth status because of the endocrine function versus pineal gland. You may have obstruction type symptoms, you may have paranods in terms of symptom finding, and these can all lead to suggestions of where the tumors are originating from. Now, historically, radiotherapy alone has been used to treat pure germ cell tumors, and essentially they're treated with 24 gray whole ventricle plus margin expansion, a boost of 45 gray. But as we think about pediatrics and the role of reducing dose, it ended up being that these pure germinomas are quite sensitive to chemotherapy. And so in the setting of children in COG studies looking at germ cell tumors, essentially patients get 4 cycles of carbotoposide followed by response-based evaluation. Those who have a complete response, they get 18 gray with a boost to 30 gray. Those who have a partial response, they have the option of going to a second look surgery. And at surgery, if they find mature teratoma tissue as opposed to viable germ cell tumor, then they can still be treated with dose de-escalation. If there's viable tissue in terms of disease after second look surgery, then the whole ventricular dose is higher, it's 24 gray with a boost of 36 gray. And so, and then lastly, if you have progression of disease, they're off protocol. For those reasons, we started looking at the role of this 18 gray with a boost to 12 gray for the complete response patients. And so what they found was that, one of the issues with this study is that they didn't meet their accrual goals. And so statistically, it wasn't as robust as needed. So this question is still being carried forward in the new ACNS study, ACNS 2321. And so even though the accrual goals were not met and the study was stopped short, we're still trying to further dose de-escalate in terms of therapy. Again, it's based on the response to chemotherapy. And so for those who have complete response on study, we're trying to go as low as 12 gray whole ventricular irradiation with a boost to 24 gray. Those who have a partial response radiographically without a second look, they're getting 18 gray with a boost to 30. Those who have those who have less than a partial response have a higher boost, and then those who have metastatic disease have a whole host of different craniospinal doses followed by boost. One thing that's interesting about this is that for those who have thalamic or basal ganglia tumors, instead of whole ventricular irradiation, they are getting whole brain irradiation followed by a boost. Now to move briefly into non-germinoma germ cell tumor, one of the study questions on ACNS 0122 is that we were wondering in the setting of those who have complete response with 6 cycles of chemotherapy, whether or not dose de-escalation can be done. And so in this study, they had a predetermined cutoff for failure, and in this study, hold on a sec. Sorry, wrong study. In this study, the stratum 1 looked at using whole ventricular and boost for non-germinal germ cell tumor. And in the study, they actually had to stop the study because they had 10 recurrences, which was their predetermined cutoff. Unfortunately, once they closed the study and they went back to retrospectively review the patient cohort, they found out that 2 of the patients that were enrolled on the complete response arm with whole ventricular boost were actually ineligible for that. And so in reality, the study never met their predetermined cutoff. And so the question became whether or not to continue the study looking at whole ventricular irradiation for complete response or to start a new trial. And ultimately, because of the bias that's been going on, they decided to start a new study. Now, they went back and looked at where patients failed. And so of the 6 patients of the 8 patients that failed, 6 patients had failed in the spine, and 2 had failed in either locally in the brain and the spine. So it seems like whole ventricular boost is a reasonable concept for those who had a complete response, but maybe patients need spinal coverage for it to get adequate coverage. So in the setting of the newest germ cell tumor study, what they're doing is that those who have a complete response, they're getting whole ventricular and total spine irradiation to 30.6 gray, followed by a boost. So this is kind of the where we're going in terms of looking at de-escalating therapy for non-germinoma germ cell tumor. Now, a lot of what we've talked about has been how to de-escalate therapy because we're doing a lot better for pediatric cancers. And so we know in the adult setting for whole brain irradiation, memantine has been shown to improve cognition. And so currently there's a study open in terms of the late effects group to look at the role of memantine in the setting of pediatric cancers. And so for those who are 40 kilograms or more, they're getting the adult dosing of memantine. For those who are less, there's a weight-based dosing. But essentially, in this prospective study, they broke up patients into 3 general cohorts. And those are the patients who received focal radiation with proton only, those who received focal radiation with photon only, and those who received whole brain irradiation and or craniospinal radiation. So we're hoping to see that we'll get similar outcomes in terms of neurocognition, but these works are still ongoing. So clearly, in the past 15, 20 minutes, we looked at a lot of success in terms of how we're treating cancers. We've learned that we can cure a lot of cancers in kids, and we're de-escalating a lot of therapies. And so in the setting of America, there's been, especially this past year, there's been a lot of media propaganda celebrating the success of pediatric cancers, including during the Super Bowl. They played Pfizer had a commercial that celebrated the success of a child being cured from cancer. In the Joint Congress in America, they invited this child who had brain tumor, who was a 5-year survivor, to come, and they celebrated the success of how we're doing. But in reality, we know that pediatric cancers are very challenging, and there are other diseases that are incurable. And furthermore, the amount of support for pediatric cancer is dramatically less than that of adult. And so to segue in a little bit, talk about our efforts in DIPG and DMGs. As we all know that this is a fatal tumor in kids. There are non-contrasting enhancing tumors that are T2 hyperintense. And prior to, about 10 years ago, it was a clinical diagnosis. You treat the 54 gray, and that's about it. But with the lack of improvement in terms of what we can do, biopsies are often employed. And for us in the US, I would say about 80 to 90% of the patients we biopsy nowadays, largely because most of the clinical trials that are available for patients with DIPG require molecular confirmation. Radiation is standard of care. Patients do a little better, but in about 6 months, they all relapse and they die. The role of reirradiation has become very commonplace in the United States nowadays. We offer reirradiation almost for everyone. And the long story short is that once patients relapse or have progressive disease with DMG, the amount of time you have to enroll a clinical trial are very limited. And so there's been multiple studies looking at the role of reirradiation, but the long story short is that what we do is we largely follow this treatment paradigm from MD Anderson, where they looked at different dose escalation treatments at the time of relapse, and essentially 24 gray and 12 fractions seems to be the sweet spot. So I treat all my kids with 24 gray and 12 fractions at relapse. More recently, Memorial published their work in terms of looking at different fractionations. They show that 30 and 10 is safe to do as well, but frankly for me, I try not to do that. I still maintain 24 gray and 12 fractions, and the real reason is because when they do progress with reirradiation, there has been anecdotal reports of a second reirradiation or third reirradiation causing symptom relief. And so you have about 10 gray and 5 fraction remaining that you could give a third course or try. So we try to keep some wiggle room there. The other reason why to keep some wiggle room there is because if they fail outside of the field and you want to treat with whole brain or craniospinal radiation while keeping the reirradiation room cool, you need some flexibility there. So generally speaking, I don't do 30 gray and 10 fractions. I do 24 and 12 to leave some room in case needed. Now, as I briefly mentioned, in the United States, there's tons of clinical trials for this disease just because there's no cure at this time. And so there's been a lot of progress with the information sharing capability as well as the ability to meet. And so two big resources that just came out last year, or 2023, so 2 years ago, is this My DIPG Navigator service, as well as the DIPG DMG National Tumor Board service. The My Navigator service are basically 3 nurse practitioners that act as virtual social workers, and they help patients across the United States get their films, give it to different institutes, access for clinical trials, get set up, and have conversations. And so this has been a big change in terms of how we keep track of DIPG patients, because if you're in a rural state or you're a small town where DIPG or DMGs are very rare, this My DIPG service can help guide standard of care and make sure that you're aware of the different trials that are available. On top of that, the National DIPG DMG Tumor Board is a group of about 12 physicians that meet every other week, and it's a free service for kids who have DIPG. Any physician in the United States can register for a discussion of the tumor board, and essentially we run through the case, we look at the molecular findings, and we essentially help patients find which trials they qualify for. We have done this for about a year now, and we just submitted our tumor board experience to Pediatric SNO, but we've since reviewed over 200 cases. Each 2 weeks, we review about 6 to 8 cases, give or take, and to date, we've reviewed patients from over 75 institutes, over 33 states. About 73% of the cases were pediatric, 21% were adult or young adults or adolescents, and majority, as we suspect, are pontine gliomas, some thalamic, and then some others. There are a whole host of clinical trials that are out there, and that ranges from CAR T-cell therapy, but more interestingly, for me personally, is focused ultrasound. The reason why I like to present focused ultrasound to a radiation oncology community is because essentially focused ultrasound is no different than non-ionizing acoustic radiation. In many ways, the concept of focused ultrasound is very similar to radiotherapy. I think it's important for our field to know what's going on in the space. So in the setting of focused ultrasound, research in this setting has started as early as in the 1900s, but it really took off about 7 or 8 years ago, largely because there's a clinical device that can deliver focused ultrasound to the brain. It's an MRI-guided device that's very similar to Gamma Knife, in which instead of cobolts placed in a spherical manner, it's thousands of elements of ultrasound arrays placed in a spherical manner, pointing to a radius. This device is currently FDA approved, and there's multiple devices in Taiwan as well for the ablation for essential tremors. But this current device has a secondary helmet that can deliver low intensity ultrasound. And why does that matter? The real reason is because in the setting of low intensity ultrasound, when you deliver the sound waves in the presence of microbubbles or ultrasound contrast, the sound waves can essentially cause the bubbles to dance to the rhythm of the beat, and this cavitation process can temporarily open the blood-brain barrier, creating a window of opportunity for drugs to leave the brain vessels to go into the brain parenchyma, essentially leading to exposure and potential drug benefit. In the United States, there's at least 3 devices that are in clinical trials. This includes the Insight Tech device that uses MRI guidance. This includes SonoCloud, which is an implantable device where after craniotomy, where the GBMs are resected, a bone window is created where an ultrasound device is placed abutting the brain, and you can basically plug yourself in like the movie Matrix and deliver ultrasound to the brain cavity. And then the last general class is neuronavigation-based ultrasound, one of which machines is developed in Taiwan. Over the past 6 years in the setting of DIPG, my lab developed a lot of the work in the setting of using ultrasound for DIPG. We opened the brainstem in blood-brain barrier in the brainstem for mice. We demonstrated that we could do it without affecting heart rate, breathing rate, and swallowing capability. It's well tolerated and reversible. So as you can see here, this is, blood-brain barrier is closed. We clearly opened the focus, and it's reversible. We tested a whole host of different drugs, and at the time, panabinostat was very popular for DIPG, and we showed in mice there was efficacy in terms of survival and local control. And we actually developed a clinical trial for kids with relapsed DMG. We're able to open the blood-brain barrier. We're able to deliver panabinostat, and we delivered all of the ultrasound within the Department of Radiation Oncology. Since then, we have, as you may or may not know, panabinostat has been taken off the U.S. market, and we had to pivot. So we actually opened a second study, and again, we were able to treat kids as young as 5 in an outpatient setting, deliver focused ultrasound with oral etoposide, and these efforts are ongoing. Since then, Children's National, as well as Sick Kids in Toronto, have opened studies using the MRI-guided devices, and they've been able to open the blood-brain barrier up to 50% of the PONS to 75% of the PONS to even patients 100% of the PONS with doxorubicin, and it's been well tolerated. So the question is, with this technology of non-ionizing acoustic radiation being able to open the blood-brain barrier, how can we potentially optimize this type of technology for kids with fatal brain tumors? And so in our first clinical trial, so one of the things we had to work out in terms of our trial using our neuronavigation device is how to set things up, but also introduce the concept of radiation oncology steps. So for example, we had patients come in for a consultation. We did a simulation where we set up the patient. We took setup photos. We did treatment planning, and then we did plan, check, and treat. We also created training programs to define who authorized users for the device was. But long story short, we delivered ultrasound to patients as young as 5 without anesthesia and sedation. We were able to open the blood-brain barrier and deliver multiple tracks to open different sizes. We started off from the cerebropontine region, and we're slowly moving our way into the brainstem. We delivered ultrasound as frequent as 3 times a week, Monday, Wednesday, Friday, all in the Department of Radiation Oncology. And we had some patients who had long-term survival with this type of stratum. So, question remains is which one of these devices is most suitable, and how can we make devices that are more oncology-driven, oncology-based? With the InsideTech device, they can open very large volumes, up to 100 cc's in various parts of the brain. But the issue right now is that this device takes multiple hours to deliver ultrasound. So as you can imagine, for pediatrics or even for adults, that type of workflow is challenging. In the setting of the implantable device can open huge areas because this is implanted under the skull. So patients basically get a little bit of topical anesthesia, and then they plug in. It's 2-minute delivery. They can open the blood-brain barrier. But because there is no targeting involved, huge quadrants are open. And so the question remains whether or not that's a good thing or a bad thing. Then with neuronavigation devices out there, you can real-time target, you can treat, but these devices can open minor volumes. And so the question is, what are the strategies to try to open larger volumes? How can we incorporate radiation oncology concepts to do better? And so, like as I mentioned before, the MRI-guided device has since opened 2 studies for DIPG patients. They've again opened huge volumes in the brainstem, 50%, 75%, even up to 100% of the PONS, and it's been well tolerated with doxorubicin. And so one of the things that I've been working on is the concept of developing intensely modulated ultrasound using standard radiation concepts. And so just like radiation, if you put a compensator in front of the delivery of the beam, you can shape how radiation is delivered. Similarly, if you know the propagation factors of sound across the bone and brain, you can 3D print a lens that can go in front of the transducer, and such that, if you want to deliver the shape of a bird, you can deliver the shape of the bird at depth of your interest. And since then, we've been doing modeling in terms of how we can design different lenses to, say, instead of opening a single focus, achieve volumetric delivery of sound waves for BBB opening. And so with these technologies and being able to open the blood-brain barrier, our next questions in terms of how we can further advance this technology is how do we prioritize drug selection? What's the role of multimodality therapy? Any role for immunotherapy, immune modulation? And then, devices suitable for kids, which I alluded to a little bit. And so one of the ways we've been choosing which drugs to prioritize in terms of delivery is we've been working with computational groups to look at single-cell RNA sequencing driven predictive models. And so one of the models we worked at Columbia is this test called OncoTarget, OncoTreat, and they're both CLIO certified tests that are available in California and New York. But the concept is that when you do single RNA sequencing, you get a whole host of gene expression that's up and down. And so what the computational approach is that it predicts protein function based on the gene expression. And from there, you're able to then predict which drugs that may be sensitive also to different molecular subtypes of the tumor. So if you imagine each column to be a different molecular subtype found in DMGs, we were able to replicate these subtypes in mice. And basically, you can now predict, for example, topoisomerase inhibitors can cover multiple subtypes, whereas if you used CDK2 inhibitors or if you use STAT2 inhibitors, they only target subtypes. And so it also leads to one to question, for example, if I combine multimodality therapy in terms of drugs that cover the gamut, can we do better? And so with these predictive algorithms, we showed that when we implant DMG cells in the flank where the blood-brain barrier are not intact, many of the drugs are responsive based off our predictive models. But once we started doing intrapontine injections where there is a blood-brain barrier, there begins to be resistance of the same drugs above. And so we're using these type of mechanisms to help us buddy up which drugs to select with our focused ultrasound delivery. We too are very interested in the potential use of focused ultrasound to deliver potential drug sensitizing agents. And so a lot of our mice work looked at how can we combine radiation with ultrasound. And so in mice, we implanted brainstem tumors. We delivered 39 gray and 13 fractions, hypofractionated as per the Egyptian regimen. And we tested the use of ultrasound a month after radiation, a week after radiation, even concurrently with radiation. And the long story short is that you can open the blood-brain barrier safely. And so that creates a lot of opportunities for either oxygenation and radiosensitization, or even deliver drugs that you could combine with radiotherapy for better outcomes. We then, like many other people, were very interested in using ultrasound to deliver immune checkpoint inhibitors. And so we optically labeled anti-PD-1, and here are our implanted tumors. We delivered ultrasound to target a big portion of the brainstem, and we saw accumulation of the anti-PD-1 therapy. When we took the brains out, you can see that without ultrasound, there was minimal accumulation of the checkpoint inhibitor versus those that receive ultrasound, and this was verified in Western blots. But the reason why that matters is because when we looked at therapeutic outcomes in mice with DMGs, and these are syngeneic models of DMGs, we showed that for mice treated with PD-1 alone or ultrasound alone, tumors clearly grew in majority of our mice. But once we started combination therapies, there was local control benefit and survival benefit. Initially, we thought that this was largely due to drug delivery, but as we move forward, we've since developed single-cell RNA sequencing data to show that in addition to drug delivery, the delivery of ultrasound and BBB opening actually immune modulates the microenvironment. And so there may be a role in terms of immune modulation leading to increased recruitment of lymphoid cells to the tumor bed to cause an effect. So what I tried to talk about in terms of focused ultrasound is that, in a disease where we're talking about DIPG, where you may or may not biopsy, but radiation is the only therapy available, the introduction of non-ionizing acoustic radiation in terms of ultrasound and blood-brain barrier opening creates many options, and those include the potential of starting to use single-cell RNA sequencing for choosing which drugs to deliver, but also the combination of gene therapy as well as immunotherapy to this fatal tumor. In addition to that, there's a possibility of combining different forms of local therapy to drug delivery, whether it be high-intensity ultrasound, histotripsy, convection-enhanced delivery. And in addition to fighting tumors, it creates an opportunity to deliver potential radiation injury or radiosensitizing options concurrently with treatment. Lastly, when you open the blood-brain barrier, there's been lots of data looking at the potential of liquid biopsy. And why that matters is because you now have a potential feedback mechanism to drive your drug selection. And this creates a potential model for precision drug delivery. And so since then, we have branched out beyond brain tumors to other metabolic disease disorders in kids in terms of non-tumor patients. And why that matters is because when we talk about oncology and brain tumors, our utility can potentially spread to patients that have non-tumor needs for drug delivery. And so one of the diseases we're looking at is patients who have creatine transporter deficiency, where they're unable to transport creatine across the blood-brain barrier, and we're looking at whether or not we can improve cognition and therapeutic outcomes. So again, here's the general schema of the different devices that are available. We talked a lot about focused ultrasound for blood-brain barrier opening, but in reality, you can do hyperthermia, you can do ablation, you can do localized drug delivery, you can do neuromodulation, you could do something called histotripsy, and all of that is in addition to blood-brain barrier, and so there's a lot of question out there. Histotripsy has gained a lot of attraction in the setting of tumors these days, largely in the liver cancer setting, where essentially when you deliver high-frequency ultrasound, you can cause dissolved bubbles in tissue to basically boil in a focused location, and they've been able to liquefy tumors for liver cancers and now extending into pancreatic cancers. So in our group, collaborators in Virginia Tech, we have since developed an intracranial histotripsy device, and so we were able to deliver clinical trials in canine gliomas, and we're essentially able to ablate these tumors. And so it becomes the question is whether or not we can remove surgery as a whole, whether or not we can use local therapies like histotripsy for the necrotic core and drug delivery, and those are kind of the things we're looking at right now. Now, I'm very thankful for the opportunity to talk about pediatric cancers and the potential role of focused ultrasound in the field of radiation oncology, largely because Taiwan is a major hub for focused ultrasound research. You may or may not know the global ultrasound meeting in 2024 was actually hosted in Taiwan. So people across the country came to Taiwan to join the meeting. Inside Tech, the MRI-guided device, early adopters were in Taiwan, and there's multiple units at this time. But also there's a company by the name of Navifus that is developed here in Taiwan as well that can do neuronavigation ultrasound. And why is that interesting is because the question is, who has ownership of this technology? Is it neurosurgeons, is it radiology, or is it radiation oncologists? And so it's interesting to me because in Taiwan, there is a precedence of radiation physicians who deliver radiotherapy, radiosurgery, tomo, to also be able to deliver MRI-guided ultrasound. And so the precedence of ultrasound being part of a radiation oncology field has been established in Taiwan. So the question is, how can we do more? How can we do better? And so a little bit about myself. I was at Columbia for 6 years, but I was recruited to Children's National of Virginia Tech to develop focused ultrasounds. I have 2 labs in the space. We do clinical trials, and we're really excited about this technology as a potential adjunct to ionizing radiation for fighting brain tumors. So with that, I'm happy to take questions and see how we can learn together. Any questions? Yeah.
Thank you very much for your talk. Out of curiosity,
Yeah.
you use the ultrasound to open the BBB. How long or the period could be the BBB be opened?
Yeah, it's a good question. So most of these devices, clinical trial-wise right now, they're using the lowest setting. And so the BBB opening time typically is between 24 hours, give or take. In the lab setting, we've been using stronger parameters, and it can be open as long as 48 to 72 hours. And so there is a range of how you can control it. And again, depending on your need of what drugs you're delivering, one can argue, for example, antibody-based therapies where you may only infuse once every 3 weeks, then once a month opening is more than enough. But for drugs where you have a pharmacokinetics where it runs in and runs out quickly and you're taking the medicine every day or you're doing continuous infusion, then you may want strategies of delivering ultrasound more frequently or having stronger parameters to control that. But these are all hypothetical and being tested in the lab.
Thank you.
Yeah.
Another question is that you just mentioned about the pharmacokinetics. Did the ultrasound, as I know, although the BBB is open, but you want to deliver medication into the tumor cell,
yeah,
you still use the diffusion.
Yes.
Right?
Yes.
So, is that any evidence or any mechanism
Yes.
study that the ultrasound can actively transport the medication into the tumor cell?
Yeah. So there are preclinical data showing that ultrasound, when you open the blood-brain barrier, it can change expression patterns of transporters and things like that. But majority of the mechanism is diffusion. That being said, there are a few major seminal studies that I didn't show in the setting of focused ultrasound, but the data is such. There's one study that came out using the MRI-guided device. They treated patients who have HER2-positive brain metastases, and they radio-labeled Herceptin. And so what they found was that when they focally opened the blood-brain barrier in brain met with HER2 positivity, the radio-labeled Herceptin was able to accumulate locally at the site. In the implantable device, because it's an implantable device, the neurosurgeons on their study were able to biopsy the tumor bed, areas that did not receive ultrasound versus those that did, and they were able to verify the BBB opening by giving fluorescein. And what they had two trials running at the time, one giving carboplatin, one giving paclitaxel. And so when they took the cohorts for both trials, they found about a 4 to 8-fold increase in drug delivery using real-time biopsy of tissue. The last study that I think is of value in the space of BBB opening and conceptually showing drug delivery is there's a study in Alzheimer's patients where they did SPECT imaging, and you can see the plaques that are distributed along the brain. And so in these patients, they delivered antibody targeting plaques once a month for 6 months. And in that study, they were able to see focal clearance of the plaque on SPECT imaging just at the area where they delivered focused ultrasound, which for their patients, they essentially opened about 1/6 of the brain. And so in their patient cohort, you can see clearance. So those 3 studies in humans basically at least convinced me that focused ultrasound, number 1, you can indirectly visualize drug delivery through the radio-labeled Herceptin. 2, you can directly see drug delivery because they did biopsies of ultrasound and non-ultrasound locations. And 3, you can deliver an antibody and see a measurable phenotype. And so whether or not DIPG is the right disease, I don't know, but I strongly believe that this drug delivery concept will be positive for something. And I think the field of radiation oncology should be aware of this technology, but we should be driving this technology as well, because the devices are largely built by neurosurgeons, and their problem is that their dosimetry, lack of a better term, is not great, and their physics is not great as well. So they're constantly trying to have better treatment planning platform and prediction. And that's our bread and butter, right, in terms of our field. And so I think that's the importance of being able to understand where this niche field is going. And I think Taiwan has a really unique opportunity to really lead in the space in the radiation oncology realm.
Thank you.
We do use NAVIFuse in the hospital. We complete the trial in recurrent GBM.
Yeah, wonderful.
But in Taiwan, it's very hard for us to initiate a pediatric trial.
Yeah.
Yeah, because the law restriction is very severe, difficult to be one population. So
yeah.
Until now, we still don't have a chance to use this technique to treat our pediatric patients.
Yeah, and I think it all depends on patient selection. So I think, in the setting of relapsed GBM or relapsed DIPG, where the survival rates are so low, that may be, at least for us. So when we first designed our clinical trial for DIPG patients, our first attempt for designing the trial was what everyone else did. We just open the BBB one time, we won't give any drugs, and just do that. But the FDA rejected our protocol. They said that there was 0 benefit for patients, so they said no. So then we went, okay, well, let's do something completely different. So then we said, okay, at the time, panobinostat or HDAC inhibitors were the more popular drug, and it's given, you know, two weeks on, 1 week off. And so we decided we're going to write this crazy study where delivering ultrasound. And our NeuroNav system is homegrown at Columbia, but it's very similar to Navifus. But since you've seen it before, I mean, we were delivering ultrasound Monday, Wednesday, Friday, and we wrote this trial to do that, and the FDA said yes. So I think it all depends on the angle of how you write your trial and the patient selection. But I can understand the challenges that you've gone through because we went through the same process as well. But I think it's about finding the right niche to be able to do that. Great, thank you so much.